A very good evening, everybody. Myself, Dr. Hemanta, fellow in vitro retina and ocular oncology. Today, I will be taking you through the top 7 articles of the last month. Coming to the first article, that is the influence of foveal glial tissue after macula hole surgery on the outer retinal restoration and visual acuity. The purpose was to investigate the impact of foveal glial tissue on the anatomical and functional results after a macula hole surgery. The study included 141 consecutive eyes that underwent successful vitrectomy for full thickness macula holes between January 2015 and December 2022. The BCVA and the length of the outer retinal defects were evaluated preoperatively and at 6 months post-op. The macula hole with retinal detachment, recurrent macula holes, and traumatic macula holes were excluded. Multiple regression analyses were conducted on outer retinal restoration and visual acuity using foveal glial tissue size, surgical technique of internal limiting membrane peeling or inverse ILM flap and high myopia as explanatory variables. Coming to the results revealed that the foveal glial tissue significantly limited the outer nuclear layer, external limiting membrane restoration, and also the ellipsoid zone restoration, as well as the best corrected visual acuity improvement. Meanwhile, the surgical technique and high myopia did not significantly affect the restoration of outer nuclear layer, external limiting membrane, ellipsoid zone, and best corrected visual acuity after the surgery. So, hence, they concluded that foveal glial tissue after macula hole surgery attenuated outer nuclear layer, external limiting membrane, and ellipsoid zone restoration, as well as best corrected visual acuity improvement. Coming to the second article for today, that is an easy way to prevent velocity-related complications during DEX implant injection in vitrectomized eyes. The purpose was to assess the impact of inserting an ophthalmic viscoelastic device into the DEX implant needle on the pellet velocity in simulated vitrectomized eyes. Here, DEX implants were injected into a calibrated ex vivo test chamber which was filled with balanced salt solution. All the DEX implants were administered by the same physician, aiming for the same button depression time. In group 1, 3 DEX implant injections were injected without an ophthalmic viscoelastic device, while in group 2, the ophthalmic viscoelastic device was safely inserted into the DEX implant needle using a 26 gauge cannula just before the injection. The slow motion video mode of the iPhone 14 was used to record the procedures and to calculate time and distance measurements. Coming to the results, Group 1 exhibited a mean velocity of 450 millimeter per second for the DEX pellet in balanced salt solution, compared with 54.57 mm per second in Group 2. Furthermore, DEX pellets in Group 1 had horizontal displacements of around 24, 29, and 31 mm, while those in Group 2 had a displacements of only 17, 16, and 15 mm. Hence, they concluded that injecting an ophthalmic viscoelastic device into the DEX implant needle significantly decreases the velocity of the free implant in balanced salt solution by 87.87%. This modification may help prevent potential velocity-related complications linked to DEX implant, especially in vitrectomized eyes. Then coming to the third article for today, that is transretinal puncture with a 41 gauge cannula for posterior residual subretinal fluid drainage in fovea of retinal detachments treated by vitrectomy versus fluid tolerance versus other conventional drainage techniques. Here, the purpose was to compare functional and anatomical outcomes between the posterior drainage of the residual fluid using a 41 gauge cannula, fluid tolerance, that is residual subretinal fluid, and the conventional complete drainage methods using including removal through the peripheral retinal breaks, perfluorocarbon liquid, and the posterior retinotomy. In this retrospective analysis multi-center study, they evaluated cases for visual acuity at 3 months of follow-up. Secondary outcomes included surgical success, the post-operative metamorphopsia, shifts, full thickness folds, OCT parameters, and safety. Subgroup analysis were also conducted. Coming to the results, visual acuity did not differ significantly between the three main groups. However, subgroup analysis revealed worse visual acuity for posterior retinotomy with significantly more grade C proliferative vitreoretinopathy changes. Residual subretinal fluid tended to offer better secondary outcomes, without statistical significance except for postoperative epiretinal membrane formation. Subgroup analysis found significantly more shifts with PFCL. No cases of postoperative full thickness folds or macular holes were observed with the 41 gauge. Hence, they concluded that introducing the 41 gauge technique indicating favorable outcomes for fovea of retinal detachments. Nevertheless, fluid tolerance appeared to be the best option, offering a cost-effective and faster method with an optimal microstructural profile and visual acuity comparable with that of complete drainage techniques. Then coming to the fourth article for today, that is pars vitrectomy with external drainage for non-exudative retinal detachment. The purpose was to describe a surgical technique for retinal detachment with undetected retinal breaks, which combines pars vitrectomy and external subretinal fluid drainage. In this retrospective observational study, the patients with a diagnosis of retinal detachment with undetected retinal breaks were enrolled. Standard 3-port 25 gauge core and peripheral vitrectomy was done. Perfluorocarbon liquid was injected to stabilize the posterior retina. Transcleral 27 gauge needle external drainage was done approximately from 8 mm from the limbus to drain the subretinal fluid subconjunctivally. Prophylactic peripheral endolaser were performed 360 degrees. SF6 20% was used as the tamponade. Coming to the results, in 14 of 15 patients, complete SRF drainage was done. In only one case, SRF did not leak out in the subconjunctival space. Neither intraoperative nor postoperative complications were recorded. Flat retina with no subretinal fluid was observed in all the samples, and no retinal detachment relapses were reported at each follow-up. Hence, they concluded that external drainage combined with pars vitrectomy may represent a valid and safe option to drain subretinal fluid in retinal detachment cases with undetected retinal breaks. The advantages of the technique include the absence of dispersion of retinal pigment epithelium cells in the vitreous chamber from dry retina and low risk of postoperative retinal folds. Coming to the fifth article for today, that is faricimab efficacy in type 1 macular neovascularization, AI-assisted quantification of PED volume, reduction over 12 months in treatment naive and switch eyes. This study evaluated the efficacy of intravitreal faricimab in reducing PED and fluid volumes in both treatment naive eyes and eyes unresponsive to anti-VEGF mono treatment, all diagnosed with type 1 macular neovascularization over a period of 12 months. This was a retrospective single-center cohort study which was conducted at the Jules Gonin Eye Hospital, Switzerland. Clinical records of treatment naive and non-responder switch patients presenting with type 1 macular neovascularization secondary to neovascular age-related macular degeneration from September 2022 to March 2023 were reviewed. Patients received a loading dose of 3 monthly faricimab injections followed by treat and extend regimen. Multimodal imaging, including structural OCT and AI-assisted analysis, was used to quantify the PED volumes and related fluid biomarkers at baseline, 3 monthly, 6 monthly, and 12 monthly follow-up. Statistical analysis included linear mixed models to evaluate differences and trends in intraretinal fluid, subretinal fluid, and PED volumes. The results were 65 eyes of 65 patients were enrolled, out of which the mean age was 80.7 years. 80% had received anti-VEGF treatment, which was a switch group, and 20% were treatment naive at baseline. At 12 months, intravitreal treatments were more frequent in the switch group, and BCVA improved at 12-month follow-up in treatment naive eyes and was maintained in switch eyes as well. No cases of intraocular inflammation were observed. Significant reduction in SRF and IRF volumes were noted in both the groups. A significant reduction in PED volume was observed over the follow-up period in both the groups. Hence, they concluded that intravitreal faricimab significantly reduced PED volumes in both treatment naive as well as non-responder switch patients over 12 months. The study also highlights faricimab's potential as an effective treatment option for type 1 macular neovascularization in neovascular AMD, offering significant improvements in PED volume and related fluid biomarkers. Then coming to the sixth article for today, that is microviscous fluid control, a simple homemade new tool to assess subretinal space in a controlled way. The purpose was to develop a simple tool to remove retained submacular PFCL bubbles and to inject recombinant tissue plasminogen activators safely in subretinal space in cases of submacular hematomas. This was a retrospective interventional study which was performed where a simple homemade microviscous fluid control was developed to gain access to subretinal space in a controlled way. Here, the rubber cap of the plunger of a 1 ml syringe was cut. The cut rubber cap of the plunger was fitted inside an empty 1 ml tuberculin syringe, and its end was fitted with the tubings of viscous fluid control of the vitrectomy machine. Now, the viscous fluid control mode was activated by attaching a 38 gauge or 41 gauge subretinal needle for extracting submacular PFCL bubbles. This group was named as RPFCL group, where the number of people were 12, and to deliver recombinant tissue plasminogen activator injection in significant submacular hematoma cases, which was grouped as submacular hematoma group, where the total number of subjects were 32. The best corrected visual acuity, fundus photographs, and optical coherence tomography were analyzed. Follow-up was done for at least 6 months. The results were vision improved from preoperative mean PCVA logarithm of minimum angle of resolution 0.99 plus or minus 0.27 to the postoperative mean PCVA logarithm of the minimum angle of resolution 0.75 plus or minus 0.21, p-value being less than 0.05 in RPFCL group. Whereas in submacular hematomas group, the preoperative mean BCVA logarithm of the minimal angle of resolution was 1.99 plus or minus 0.05, whereas the postoperative mean BCVA logarithm of minimal angle of resolution was 0.75, where the p-value was less than 0.001. Hence, they concluded that homemade microviscous fluid control is a safe tool to extract retained submacular PFCL bubbles and also to deliver a precise dose of subretinal drugs like recombinant tissue plasminogen activator for a subretinal hematoma in a controlled way. Coming to the last article for this month's Retina Roundup, that is anterior subtenon triamcinolone injection for refractory macular edema. The purpose was to evaluate the effectiveness of anterior subtenon triamcinolone injections in the management of refractory macular edema. This was a retrospective case series of consecutive eyes with refractory macular edema, which was treated with anterior subtenon injection at a single vitreoretinal surgeon's practice at Toronto Western Hospital, University of Toronto, Canada in 2018 to 2023. Refractory was defined as persistent macular edema with a central subfield thickness of 250 micrometer or greater over a 24-week time, receiving at least 4 intravitreal anti-VEGF injections. Vision outcomes and optical coherence tomography features for all eyes were compared for 3 visits pre-AST treatment and 2 visits post-AST treatment. The results were 93 patients, 119 eyes, uh, where 26% were diabetic macular edema cases and 74% were pseudophakic CME cases, with a mean follow-up duration of 161 days were included. The presence of subretinal fluid, central subfield macular thickness, cube average thickness, and macular cube volume significantly improved from pre-AST to post-AST treatment. Visual acuity also significantly improved from pre-AST treatment to post-AST treatment, where P was less than 0.0001. There was no significant change in the intraocular pressures from pre-AST to post-AST, and no complications were noted throughout the follow-up period. Hence, they concluded that AST injections show modest improvement in anatomical and functional outcomes and are safe for the treatment and management of refractory macular edemas. Thank you everybody for the patient listening.